Hi, I'm Kate Grace. Welcome to Move Without Limits Club podcast. I always follow up a live podcast following an interview I did. I hope many of you saw Dr. Kopp's podcast last week. Dr. Stephen Kopp, he's head of total joint surgery at Scripps Hospital in San Diego, and he is not only a phenomenal surgeon and good and caring doctor, he's just such an amazing and loving person. So if you haven't, please go back and watch that. So from that, we got a lot of questions about different knee pains, different surgeries. So we're going to cover a lot of that today, including total joints. So I had a patient once who walked in our clinic and said, well, my knee hurts, so I think I'll just get a total knee replacement. No, that's not where you start. You don't start there. You start with conservative physical therapy. Then maybe you do other different types of injections, and maybe you get to the point where you are ready for a total joint. But it's a big operation, and you need to be ready. So how do you know when you're ready? Well, if you can answer this question, I've exhausted all other best options. And I mean best options. I mean best physical therapy, best, maybe you did some deep tissue work, maybe you did some acupuncture, maybe you've lost some weight and you've changed your nutrition, you've increased your exercise. But when you get to the point where you say, I truly have, and maybe some of you don't know about this, and if you don't, go back and watch our podcast with Dr. Chris Rogers on regenerative medicine. But maybe you've done a PRP injection, maybe you've done a stem cell injection, and it also has to be with the right person. Make sure you don't go to somebody who just took a weekend course at the Height and calls themselves a regenerative medicine specialist, because they're probably not going to help you very much. So maybe those help. We had a patient who was in her 80s who was not a good surgical candidate, but she could barely walk, did stem cells with her, and that was about 5 years ago, and she still has not had a total knee replacement. So there is a huge, huge parameter of things you can do before you're ready for a total knee. So let's say you say, okay, I can't do the things I want to do in life, and it's too painful. I can't even play with my grandchildren. Okay, you're ready. Well, before you even you've made that decision, but it's months away, and there's all kinds of things you can do beforehand. So it's called prehab. And so what is that? Well, that is changing maybe your nutrition, getting better sleep, getting your house ready, removing all of those rugs that you could slip on, and specific exercises to strengthen your knees. So when you do have surgery, your outcome will be better and easier for you. We created this 25 video series. It's on our website, ourjointeffort.com, and you go up to the tab where it says, I think it says total knee. 25 videos covering everything from before you even think you need one to all the way through the end. And in that, I show you specific exercises for you to do before surgery that you will be able to do pain-free to get yourself ready. So let's make the post-op rehab easier by doing some work before. Now, we also know, I wouldn't want you to have this when you're young. We also know that they last about 25 years. So you don't want to have a revision after you've had one. You really don't, if you can avoid it. So have it at a time in your life where you won't have to have another surgery. And also, there are so many risks and complications. There's infection, there's blood clots, there's heart and lung risks, there's increased scar tissue, there's decreased range of motion where you don't get your flexion or extension or be able to bend and straighten your knee all the way. There's poor outcomes, and there's death. So it is a risky surgery. Don't let anybody tell you it's not. And you need to go into this with a lot of information and certainty that this is your best option. So let's say that you've decided, okay, I'm going to have it. What's your next step? You got to find the right surgeon for you. And please get 2 or 3 opinions. I got 2 or 3 opinions, and I know pretty much what I'm talking about when it comes to this. And I went to one doctor, I went to the next doctor, and I went to the third, which was Dr. Kopp. I told him it wasn't in that order. It just probably took me that long to get in to see him. And I'll tell you what he did after he answered all my questions, and some of them very complicated. My legs went really far in, so much so that my knees were almost touching each other. So I wanted him to straighten out my legs. And I said, what are you going to do to fix this valgus in my knee? And we talked about cutting the bone and doing an osteotomy and straightening out my leg. So there was a lot of complicated things in my surgery. And he sat down, he answered all my questions, like he had all the time in the world. And at the very end, he got up and he walked to the door and he turned around and he said, Kate, I look forward to taking really good care of you. And at that moment, I knew he was a doctor for me. So you need to find a doctor in your area that you know will take care of you, good, bad, or ugly. You know, there with these complications, let's say it's 1 in 500,000. Well, you don't think you're going to be the one, but somebody's the one. So let's hope it's not you. But if it is, I had 2 very tough complications after my both total knees. I've had 10 knee surgeries. Last 2 were total knees. And I had a very, very challenging, huge inflammatory response in both my legs, both times. And he took really good care of me and fixed that. So I can't think of too many other doctors who would have cared for me as well as he did. So when you go to the doctor, let's say you've picked your doctor, bring any studies you've had done. So x-rays, MRIs, and I would bring the actual study. So wherever you went to have it done, go to them and say, I want my study on a disc. And I want to take that to my doctor, because a good doctor will look at the actual study, excuse me, and not just a report. We've got all these fancy studies, we've got MRIs and CT scans, but they're still read by a human. So there is an opportunity for them to maybe miss something or misread something. So you want your doctor to look at it. So make sure you bring those with you. And not an unreasonable question is, how many of these have you done? You know, maybe they're fresh out of residency. I probably wouldn't choose that person. Or maybe they're about to retire. I might not choose that person either. I would go to somebody who's done at least several hundred and maybe more. It's fine to ask them that. They won't be offended. And let's say you have other challenges in your legs. Ask them how they're going to fix those. Ask them what hospital. Ask them if they do it as an inpatient or outpatient. If you're young and healthy and don't have any comorbidities or other illnesses, maybe you can have yours done as an outpatient. It's called a 23-hour stay. So surgery centers are allowed to keep you for 23 hours, which means you're not an inpatient, and let you go home the next day or go to a facility, a rehab facility, if that's what you've chosen to do. So those might be options. I would, if I couldn't because of the challenges in my legs, but if I could, I probably would have attempted to do it in a surgery center, because there's a lot less germs there than in the hospital and a lot less chance of getting an infection. I have a very hard time with anesthesia. Thank you, Mom. I'm very sensitive to it, and every surgery I've had, I vomit uncontrollably from those heavy-duty medications. So if you're like that, make sure you talk to the anesthesiologist, or tell your doctor you want to talk to the anesthesiologist first and tell them that, and have them create some cocktail that will minimize that. I now have a cocktail after all this time that works for me. There's a couple really good drugs that you can take before that minimize that, and drugs they can give you in the operating room that will minimize it. And for my last couple surgeries, I've been fine. So you can solve that problem. So you've had surgery. When do you start physical therapy? That's a good question to ask them too. If your doctor says, well, we keep you at home and we do home physical therapy, no offense, but it's really not very effective, for about 4 to 6 weeks, and then we start, that's not the person for you. We start almost the day or day after you get out of the hospital or the surgery center. And I'll tell you why. You're not going to have pain in your knee like you did before from your arthritis and your cartilage wearing down. You're going to have post-surgical pain. And the reason you have post-surgical pain, one of the main ones, is because it's going to be really swollen your knee. And that swelling pushes against all that tissue that's highly innervated, nerve endings, and that's what's painful. So start physical therapy right away. We get your leg up in the air. We work the swelling out. We give you things to do on your own. and we start squeezing that swelling out of your knee and have you start activating your muscles so you can squeeze it out yourself. It's really for your comfort to start right away. And it will also make your rehab probably a little less in terms of length if you start right away. What will help you at home? Well, there's a couple things I could not have done without. A polar care or any kind of ice system. Now you can have somebody bring you ice packs all the time. Oh, and by the way, your post-op instructions will probably say 20 minutes on of ice, 20 minutes off. Both BS. Keep it on the whole time because it'll make you more comfortable and it'll keep the swelling down. So I have a thing called a polar care, and it looks like a little ice bucket, and you fill that up with water and ice, and there's a tube that comes out of it onto a pad on your knee, and it keeps cold circulating around your knee all the time. And all you have to do is have your friends and family who are helping you just fill that ice bucket up. So that's a must. I also truly believe that a CPM machine is also a must, which stands for continuous passive motion, CPM. Ask your doctor about that. Now, most surgeons don't know a lot about it. It was created by a physical therapist and an engineer to constantly move your knee passively after surgery to get the swelling out. So that will help you maintain. Let's say you go to physical therapy and you get 20 more degrees of knee flexion, and you go home and you get in that machine and you have it bend your knee all the way up to your new range of motion. Your chances of keeping that range of motion visit to visit is going to be much greater than if you didn't have that. I used it for both my surgeries, and probably for a good couple months is when I used it until, because this surgery is awful. We use a lot of Black & Decker saws, cut a lot of bone, cut tissue away, and hammer in your new joint, and it causes a lot of tissue damage and a lot of swelling, and that's really what you're going to get the pain from. So the more you can minimize that, the more comfortable you're going to feel, and the faster you're going to get better. So these are just a few thoughts and ideas. When you go through therapy, your physical therapy should progress every week. So if you do this today, you should progress and do something different the next day. And your therapist should get their hands on you every single visit. And this is for every knee surgery. This isn't just total knees. This is ACLs and meniscus and any other kind of knee surgery that you have. And every time they should be changing the mechanics of your joint and then progressing you each time. Physical therapy is not come in, say hello, do it, look at you a little bit, and then go do a bunch of exercises. That's not physical therapy. If you have that, you haven't had physical therapy yet. I had a patient this week who has really severe bilateral knee pain, went to therapy 4 times, and none of those 4 times they put their hands on her. Not one. Not even during the exam. I don't even get that. That drives me crazy. So again, one of our missions of our joint effort is to stop this terrible advice, misdiagnosis, no resolution of your problem because you didn't get the right thing. If you're in some area and you need somebody, contact me. I'll find you somebody good, because I've done telemedicine and telehealth for a long time now, since 2020. I've amassed a pretty good group of physical therapists around the world, and I'll be able to help you. And if I don't have some in your area, I'll find somebody, because in truth, even surgeons will tell you this, your result after surgery, whether it's a total knee or something else, 20% of it is the surgery, 80% of it is the rehab and what you do after. And it's frustrating that first month. You don't sleep well, and just chalk that up to that's part of the process. You wake up every morning and you feel like somebody poured cement in your knee once again, because you've let it be stagnant at night and the fluid hasn't moved in and out of it. So you got to get up and start moving it again. But it will get better. It will get better every day and every week. So just be positive, have faith, trust trust in the therapy, and it will get better. So through our video series, we take you from how do you know you need one, all the way through what do you do 3 months up to the time of surgery? What do you do? What surgery look like? When do you start physical therapy? What really good physical therapy is, and then all the way through sports specific training to get you back doing what you want to do. And so that should answer all of your questions. In fact, I had someone who watched the video series. She said 90% of what she learned in that video series, her doctor did not tell her. So I'm hoping that I can help educate you and that you are wildly prepared before you have surgery. I had a patient a couple years ago who contacted me, and she was in her mid 70s and very active. She walked her 80-pound dog, she kayaked, she biked, and her knee started bothering her. So she went to the doctor without doing much of an exam. He said, well, you need a total knee. And she thought, wow, that kind of sounds kind of aggressive. So she contacted me. I saw her. I said, bring your x-rays. Well, I think most of you know that the reason we do a total knee is you've worn your cartilage down in between your joint, this cartilage in here, and you've worn it down so you don't have that good bushing or cushion between your joint. And you've now got this bone on this bone. So it's rubbing against that bone on bone. It's very painful. So when you look at it, x-ray only shows bone, but what it does show, it shows the joint space between these two bones. So if you have a lot of space between those bones, you've got good cartilage and joint space. You can also see it on an MRI. So I said, well, bring your x-rays and let me examine you and let's see. So she comes in and I examine her. And when you examine a patient, not any of you healthcare professionals watching this, you know this, when we see people with a lot of arthritis, your knee, what I call it is it ratchets. Like if I bring your knee, and maybe some of you have had this before surgery, and I bring your knee through range of motion, it kind of goes, it's a horrible feeling for both the patient and the treating healthcare professional. But that kind of helps you know you've kind of worn down your cartilage. And there's also very specific tests we do to determine if you'd worn your cartilage down between these two bones and behind your kneecap. So there's specific tests we can do to determine that. I did all those tests on her. She didn't have any of those symptoms. I looked at her x-rays. She had great joint space. So I determined she really had good cartilage. I thought, why in the world would you do a total knee on this person? Well, she ended up, what she was doing was she got caught when she was cycling. Her patella, kneecap, got caught between her synovium, or the lining or the thin membrane around your joint, pinched it, which is highly innervated with nerve endings, and her knee got swollen and sore. And I said, well, this is easy. We'll just make sure your kneecap's in the right position. We'll work on loosening up this tissue. We'll address everything else because it's always down the chain. She had a little hip tightness. She had a little dysfunction in her feet. Treated all that, treated her knee 2 weeks. No knee pain. And this was several years ago, and she still has no knee pain, and she's doing all the things she wants to do. So I would just be cautious. And, you always get a couple opinions, that, but just be cautious if someone is rushing you into surgery that doesn't consider other options first. I talked to this really great, I think a really great naturopathic doctor last week and just today. And I finally found, for all of you, I think I finally found someone really good and honest and ethical in the peptide world. So I'm going to talk about peptides in September. I'm going to have him on. But he and I agree in this. When you see someone, you pick the low-hanging fruit first. So you talk about your activities. You talk about your sleep. You talk about your nutrition. You talk about your exercise. We go there first to see if we can change or modify or inspire or make improvements in those areas, and before we do anything invasive. So when someone says we're starting with surgery, I would quietly say thank you very much and get up and leave and go find somebody else. Maybe I can help you find somebody in your area with that too. But I just couldn't believe that. We also, I had a patient who, she's not a patient yet, but she will be. I saw her watching people play pickleball about a week ago, and she was kind of hobbling around. I said, "Hey, what happened?" And she said, "Oh, I tore my meniscus, or the cartilage in your knee, which is this cartilage right here between these two bones. So you have one on each side, your meniscus or your cartilage." And so I had meniscus surgery. I said, "Oh," I said, "did he offer you therapy beforehand to see if, because we fixed a lot of those in therapy?" "No." "Well, did he offer you a PRP injection, which would heal the tissue, a tear?" "No." And when was this? March. Now it's the end of July now. And I said, "Well, and you're still," she said, "my knee's still swollen and I still don't have all my motion." And I thought, this is crazy. If she was our patient, she would have been back playing pickleball in April. I mean, I said, "Well, did you have therapy?" And she said, "Well, yes, but she's kind of a friend. So we just kind of talked the whole time." And I thought, oh my God, this is going from bad to worse. So, oh, it's okay if you're friendly with your therapist, but it's not what they should be doing while they're attempting to get you to recover from surgery. So I say all this because, and here's what she said, and I quote, first of all, I said, "You've not had the best care." And she said, "Well, I just did what they told me to do." And I've heard that my career so many times. If you go jump off that Coronado Bridge, that's going to solve your shoulder problem. Well, don't take that at face value. A lot of you guys are very savvy these days. You're looking on the internet, you're finding things out, but consult somebody really good in that area and make sure you, again, get different opinions. Oh, I asked her, "Did you get another opinion from?" No. So she did everything wrong. So I'm hoping I referred her to someone else that I thought would get their hands on her and she would have a really good outcome. So it really doesn't matter whether you have surgery on your knee, your shoulder, your ankle, your elbow, your back, or your neck. You just got to find the best people and get the right therapy. So I'll tell you one more thing. I actually, there's a orthopedic surgeon who will remain nameless, in a city where I used to live. And he admittedly, if you have a complication in surgery, he won't see you afterwards. How about that? So make sure you ask about what your post-op care is going to be like. How soon after surgery are you going to see me? How many times are you going to see me after that? I'm going to see you once a week, once every 3 weeks, what if I have a complication? Are you going to take care of that with me? So it may not occur to you to ask those questions, but you have to ask those questions because this is what is going on there in the world in some areas. Yeah, there's some great people, but there's a lot of not great people too. Before we get into Ask Kate Anything, I'm going to answer your questions, and I'm happy to, but I'm going to start another segment, which my lovely producer doesn't even know we're going to do, and I'm calling it Crazy Things I See at the Gym. Because every time I go to the gym, I see something crazy. And if you're a gym rat and you like working out there, great. But I saw this gal on the Stairmaster, and the elliptical. And it would be safe with Stairmaster. The elliptical, you know what that is. So you're standing there, pumping your feet up and down. She had literally were on her toes, and she was pushing down like this. And she was using her foot and her calf. And she was going as fast as she could. And I thought, you're going to tear your Achilles or something. She was overusing her calf. So what I coach my people to do is, we're on that elliptical. I want you to feel like you're pushing down from way up here in your pelvis. Push down from your pelvis and your hip, and push down and push down and push down. That way you're going to use your whole leg. You'll engage your abs and do a variety of slow, fast, but push down with your whole leg. I hope I don't see this again, but I've seen it enough times. Thought I'd mention it in our crazy things you see at the gym. And I'm going to be telling you those stories every other week on our podcast because there's a plethora of information. So let's move on to our favorite segment, AKA Ask Kate Anything. And I'll find out if we have any questions.
We do. We have someone that has said, hi, thanks so much, Pila. Hi, thanks so much for this information. Very good. Love your honesty. Have you ever heard of a Jiffy knee surgery?
Oh, spell it Jiffy?
Right, like Jiffy Lube.
Wow. Jiffy Lube, maybe it is. Well, thank you for that. Have you ever heard of a Jiffy surgery? And I thank you for your comments about being honest. I don't know any other way to be. So I've not heard of that. I don't know if it's a total knee surgery or a different type of surgery, or if it's a robotic surgery, but I will look it up and I will answer your question in the comments on YouTube. You can find our podcasts on YouTube, LinkedIn, and Facebook for now, and pretty soon we'll have them on many other platforms. But I like to answer the questions on YouTube because I think that's where most people are familiar with getting on podcasts and finding us. So I will look that up and answer you within 24 hours. Thanks for the question, though. Thanks for stumping me. Thanks, producer.
Ben wants to know, how do I know if it's arthritis, a meniscus tear, or something else?
How do I know if it's arthritis, meniscus tear, or something else? A good exam. I can examine you with no tests, no MRI, no X-ray, nothing else, and determine if it's patellofemoral dysfunction, meniscal problems, ACL, PCL, MCL, LCL, or arthritis. A good exam. Thank you. That's definitely how you figure that out.
And Sheila has responded again about the Jiffy knee.
Oh, Sheila, thanks.
She said they come in medially versus in the top of the kneecap.
They come in medially versus the top of the kneecap. Well, I don't know if she's talking about total joint or not, but there's different types of total joint surgeries. Most people don't know this, but total joint surgery started as a uni. They started as doing one half. So if you just have, and it only can be on the medial side, which is the inside, this is the outside where this bone is. So if you just have pathology or decreased joint space on one side, you could have a uni, so that's one side, total knees, where we cover one side of the femur with titanium, then put the plastic insert on one side, cover the tibia with titanium, and then the patella. That's how they started. But now they've gone to doing both sides, but there are some cases where you can just do one side. I don't know what approach he's talking about, but we do what's called minimally invasive approach. And the approach usually is along the side of the kneecap. So you definitely don't go over the top of the kneecap at all. You go on the side for tissue healing, so you can do the sutures along the soft tissue. And so when you're bending and straightening your knee, you're not pulling it over the patella. But I'll find out more about that. It may be just an approach, because for the hip, for example, different surgeons like doing total hips with an anterior, lateral, posterior approach. So it really depends on the patient and the surgeon's preference. But I will find out, Sheila. Thank you, Sheila.
She said, got it. That may be it.
Oh, thanks, Sheila. But I'm gonna delve into it more, Sheila, for you.
And Bobsy would like to know,
Bobs,
why would the knee swell after a total knee even 10 years later?
Why would a knee swell in a total knee even 10 years later? Well, that's one of the things I mentioned early in the beginning, where part of the risk of a total knee is a poor outcome. There may be something in there that is continuing to irritate the joint. It could be the tissue, it could be the patella position, it could be anything. It really should not happen. And so if that's the case, I go back to the surgeon, because you really shouldn't have to put up with that and say, hey, why is my knee swelling? It shouldn't. And it should really be painless and should be able to do pretty much whatever you want. I also, saying that, I don't like my patients to do compounding sports. I wouldn't want them to be a big runner or a marathoner. Some pickleball and some tennis doubles is fine, but I would stick to activities that are less compounding. on the ground. And let's make it last as long as it can, whether it's a total knee or something else. Let's make sure that your outcome lasts as long as you want it to in a positive way.
Chloe would like to know how long she should try physical therapy before considering surgery.
How long should I try PT before considering? It goes back to my initial statement. You want to feel like you've exhausted all possibilities. So I like to tell people that they need to give it a minimum of 3 months. And that's a couple times a week, each week, and in the right hands of the right person. Then you can say, okay, I gave it everything. Maybe I had some injections or maybe not. So I've talked to a lot of surgeons, and I was part of this international patellofemoral study group for a long time. And I had a lot of conversations with these surgeons about this. They say, Kate, I agree with you. I want my patients to do physical therapy first, but they go somewhere where it's crappy therapy and they don't get their hands on the patient. They go have them do a few little exercises, and the patient comes back to me and say, well, doc, I did what you said and it didn't work. And then they say, well, now what do I do, Kate? I know it wasn't great, but either they're limited to where they live, their insurance or whatever it is. And he said, I feel like my hands are tied, then I have to offer them some solution. So great question. Make sure it's the best treatment before you make a surgical decision, because you can't undo that. You can always do surgery, but you can't undo surgery.
Christy has asked, are injections like cortisone, PRP, stem cells worth it?
Are injections, cortisone, PRP, stem cells worth it? Well, those are 3 different things. And I would say yes to PRP and stem cells for sure. If you want to know more about this, go back and watch our podcast with Dr. Rogers and the subsequent one I did on regenerative medicine injections and how we use them and treat them. But PRP, if you have a torn soft tissue, ligament, cartilage, muscle, tendon, IT band, lateral epicondylitis, does great. Stem cells are used for people with severe osteoarthritis. So in this case, when you've worn down your cartilage, you would want to experiment or go see somebody, and I would only go see this Dr. Chris Rogers in Carlsbad, California, and because he does it right, to do stem cells and see if that'll help. I'm not a fan of cortisone, and I'm glad you asked this, because cortisone is a steroid. It does not fix the problem. All it's designed to do is draw swelling out of a joint or your back or anywhere else. So it pulls fluid out. That fluid got there for a reason. There's a mechanical abnormality that caused that to happen. Why wouldn't we discover the cause of that and get rid of the mechanical problem or malalignment or orthopedic challenge that's causing the swelling, and therefore the swelling will go away? The other reason I don't like cortisone is because when we do PRP and stem cells, those cells are so smart and they regenerate and they go proliferate and they go over here and say, hey, your cells, you don't normally do this, but come over here and do this because we need to regenerate this tissue. Cortisone inhibits that action from happening. And the third thing is that cortisone takes your nice, soft, pliable tissue and makes it short and fibrotic, and it will be that way. So doctors a lot of times like to use this because it's great. It's a short-term fix and they look good because maybe you're out of pain for a couple of weeks, but it's not going to fix your problem. So don't do it. I am very much against it in most cases. I'll tell you when I would do it. And when I think I've seen a lot of patients and doctors get to this point. They're at the point where they're going to do a total knee and they don't really care if they wreak havoc on your tissue. And so they want to give you, maybe your surgery's not for 3 months or 2 months or a month. They want to give you some relief short term. Okay, do a cortisone injection, get some relief short term on your way to surgery, knowing they're going to damage tissue in there anyway that they're going to take out. Or you just have this, I had it several times after my knee dislocations, huge ball of fluid in your knee where you just can't work it out. They would drain the blood out of your knee and then do a cortisone injection to try and get that swelling to go down. Those are really the only 2 situations where I think it makes sense to do it. but not as I've had patients. I had talked to someone this week. Well, my shoulder hurts, went to the doctor, and they did a cortisone injection. I said, did they do anything else? No. Do they recommend PT? No. So that's the absolute wrong way to use it, as a Band-Aid to get you through it, because it's not going to last. It will not last. Good question.
One final question
Let's
here
take
from
one
Jake.
more. Okay, Jake.
Do I need imaging like an X-ray or MRI right away?
Do I need an X-ray or MRI right away? No, you don't. If you go to a good doctor and they do a good exam, then they will determine what's wrong with your whatever joint it is, and then they'll send you to physical therapy or do whatever type of conservative care that they feel necessary. Lots of times they'll do, I like to reserve X-rays and MRIs to confirm or deny what we see on the exam. We don't use MRIs, especially, we never make a decision on what to do with a patient, what treatment based on the MRI, because there are a huge percentage of false positives and false negatives. I have been in surgeries where the MRI said complete ACL tear, MCL tear, like 3 things are all wrong. And we go in there and they're not torn. Trust me, this has happened more than once. Then conversely, we'll get an MRI that says, well, maybe, kind of, could be, and we'll get in there and everything's torn to shreds. So you make a decision based on the history you take of the patient, your exam, and then how they do with your specific treatments, not based on a test. Tests are great, but they're an adjunct. They're additional piece of information. And 2 years ago, I remember I was walking down to the tennis courts and this gal stopped me and said, hey, I've got shoulder pain, so I think I'm just going to go get an MRI. I said, have you seen anybody? I said, no, I'm just going to go get an MRI. I said, okay, but that's not where I would start. So thank you all for these questions. I'll remind you, you can watch all of our info, our shorts, our longs, our podcasts, all on YouTube. Our channel is Move Without Limits Club, also on any other areas where you get your podcasts. And I'm looking forward to our next one, and looking forward to the truth about peptides and how you use them and how they can benefit you. They are an important amino acid in your body. When clustered together, create protein. That's great, but they should be used for what they can do and not as a substitute for something else. So we're going to bust all those myths, give you the truth about that. And I thank you for tuning in once again. It's always a pleasure to share our information, answer your questions, and have some communication with you. And many of you, I will see you tomorrow morning in our 50 Shades of Grace functional fitness class. Thanks, everyone.